This film is about a technique in which the amputation of an IOL haptic can be used as a solution for crystalline lens subluxation. The authors have no financial interests in the methods and materials shown in this film. Crystalline lens subluxation can be due to trauma or can also be related to congenital causes. Every time we see a patient that was born with lens subluxation, we know there is an evident area of zonular weakness, but it is very important to remember that besides this area, there is also zonular weakness 360 degrees. Thus, when we suture a ring or ring segment in this patient's sclera, we consequently generate stress in the contralateral zonules. Thinking about this, we decided to have a plan B with regards to these cases, and that's how we came up with the Ventura amputated Iol haptic technique. This technique has been published in many papers and book chapters, and it consists of very simple steps. First, it consists of the implantation of a capsular tension ring to obtain partial bag centration and a 360 degrees decrease in zonular tension. Then we insert a 3-piece IOL with partial amputation of one haptic. When this technique was developed in 1999, we used a PMMA lens, but soon we changed for a 3-piece IOL. After these two steps of the CTR implantation and implantation of a 3-piece IOL, we can see how the IOL optic is centered in the patient's visual axis. To illustrate this technique, we're going to show the case of this 19-year-old woman that presented to us with low vision since childhood. Her best corrected visual acuity was 2100 in both eyes with this refraction. In the slit lamp exam, we could observe bilateral crystalline lens subluxation. In these cases, we have two main challenges: performing the capsular rhexis and obtaining centration of IOL optic. For the capsular rhexis challenge, we decided to use femtosecond laser to aid us, and for the centration of the IOL optic, we decided to use the Ventura technique. The femtosecond laser has no problem in imaging and treating these eyes with crystalline lens subluxation. In the operating room, we see the lens subluxation. It is very important to start these cases filling the anterior chamber with viscoelastic to protect the zonular remnants. Then we insert a CTR to expand the bag 360 degrees and relax the zonules. We are phacoaspirating the nucleus, and then we aspirate the cortex. We can always use a cannula with BSS to gently remove the remaining cortex. Here's a view of the eye after the CTR implantation, and we can see how the bag is better centered than when compared to before implanting the CTR. At this point, we're ready for the IOL implantation, and we're going to plan where we're going to partially cut the IOL haptic. The leading haptic is always the intact haptic. After the lens optic unfolds in the eye, we hold onto the partially amputated haptic and we rotate the lens until approximately where we want it located at the end of the surgery. Then we use our secondary instrument to do the final adjustment in the lens position. Here we see the eye at the end of the surgery and how the IOL optic is centered to the patient's visual axis, even though the capsular bag is not perfectly centered. In the first postoperative day, we see a very stable lens with minimal pseudophaco iridodonesis that maintains in the first year post-op. With the eye dilated, we see how the lens is exactly where we left it at the end of the surgery, and the lens is very stable. If this opacification of the anterior capsule is visually significant, we can always treat it with the YAG laser. The patient's uncorrected visual acuity 1 year after surgery was 20/30 in this eye, achieving a best corrected visual acuity of 20/25. In order to use this technique, it is important to have less than 210 degrees of subluxation, zonular remnant in the area of subluxation, and absence of vitreous in the anterior chamber. We published a paper in 2010 reporting the complications in 17 eyes of 10 patients with a mean follow-up of 2.8 years. None of the patients had intraoperative complications, and 59% of them developed posterior capsule opacification that was treated successfully with YAG laser. Since 1999, we have been using this technique, and we see that the patients do not have progressive decentration of the BEG-IOL complex, the pseudophacoiridodonesis decreases with time, and when patients are operated younger, there is even less pseudophacoiridodonesis. But which other cases can benefit from this technique? Well, patients with other capsular BEG anomalies. This patient, for example, had BEG fibrosis causing capsular retraction and ciliary body ectropia. After cataract extraction, we faced the challenge of implanting an IOL. We decided to implant the IOL with the superior haptic partially amputated so that the IOL optic could be centered in the patient's visual axis even though the entire left part of the BEG was retracted due to the fibrosis. Other patients that can benefit from this technique are patients with microspherophakia. This is an example of a patient that had congenital cataracts and microspherophakia. After the cataract removal, we were left with a BEG that was too small to implant a lens in a routine fashion. So the solution was to partially amputate both of the IOL haptics and implant the IOL in the patient's BEG. We see that we have no difficulty in placing the lens inside the BEG. At the end of the surgery, the lens is stable, and when we start closing the pupil, we see that the lens optic is centered in the patient's visual axis. So in conclusion, the amputation of an IOL haptic can be the solution to crystalline lens subluxation and other BEG anomalies.